Thank you so much, Dr. Dua, for joining us here on MD Newsline. Can you please introduce yourself and tell us a little bit about your work?
Yes, so my name is Dr. Duah. I am a physician in internal medicine. I also specialize in obesity and lifestyle medicine. So I do a lot of primary care, but also do some extra education and weight management.
Obesity is a hot topic, I feel like, no matter what's going on in the world, but I know that a lot has changed in how we end up define obesity. So what's the current definition of obesity, and what's its current impact on the American population?
Right. So I think in the past, people used to think of obesity more as a moral diagnosis, like someone is not doing exercising enough or eating well enough, and kind of putting the blame on the person who suffers with overweight or obesity. But we now actually have a more, I guess, humane diagnosis or definition for how we talk about overweight and obesity. I think recently the Obesity Medicine Association came out with this definition that describes it as a chronic illness that's relapsing and can recur, that is neurobiological, physiological, psychological, and environmental in its etiology. So it's more so about incorporating all the external factors that govern somebody's weight and their weight management, more so than it being kind of blaming the person for being overweight or obese. So it's more looked at as a chronic illness than an issue with the person and their habits themselves.
Can you go into some of those factors, especially with neurobiological? That's the new one that I haven't heard about.
Yeah, so there's a ton of things that manage someone's weight. So in general, our brain, our hypothalamus has a set point, so a body weight set point. All of our brains have, from external and internal inputs, what your brain thinks your weight should be. And because of a lot of external inputs, like what we eat, how we exercise or don't exercise, how what we like supplements and antibiotics, how it affects our gut flora, things that we watch on TV, all of those things are inputs that our brain takes in. And we currently describe our environment as obesogenic, meaning it leads to obesity. So there's a ton of factors that are set up against us that lead to this overweight and obesity epidemic that we have.
So, about what percentage or how much of the population would you say qualifies as being obese? And then what factors go into that qualification?
Yeah, so right now, I think the latest data suggests that about 1 in 3 people are overweight or obese, and actually a larger proportion of that is in the higher classes, so class 2 and class 3 obesity. All the classifications, like we have shied away from calling people morbidly obese. We now use class 1, class 2, class 3, and that's all BMI based. So class 1 is, well, let me backtrack. Overweight is having a BMI between 25 and like 29.9. And then class 1 obesity is 30 to 35. And then class 2 is 35 to 40. And then class 3 is 40 and above. So it's all based on your BMI.
So I've heard so many things about BMI in general,
Mm-hmm.
and so tell me a little bit about what BMI is, and have the parameters for measuring BMI changed at all?
So it's a very antiquated way of measuring what is considered a healthy weight. It's an equation that takes into account someone's gender and their height and their weight. So it's basically a ratio of your height to your weight with some extra math in it. But it is an oversimplification of what should be considered a healthy weight. We actually have research now that suggests that the BMI underestimates health issues related to weight for Asian populations. So for instance, we see insulin resistance and diabetes in BMIs of 23 and above in Asian populations. And it also overestimates risk for people of color, like Black people. So we know that when we're seeing patients who are technically overweight or even class 1 obesity that are of Black descent, it's actually overestimating their cardiovascular disease risk. So we have to take the BMI with a grain of salt. There's many other ways of gauging what should be a healthy weight for a person.
So what are some of those other ways of gauging healthy weight?
So for me, when I am doing an intake for weight management, first of all, or like when I'm seeing a patient, first off, to gauge what their goal weight should be, there are a couple of different things that I take into account. So BMI is one because that's the most readily accessible thing that people know. So they often are like, I want to be whatever makes me a healthy BMI. But we have to think about what health means. So a healthy weight for me is one that supports your health. So you have well-controlled blood sugars, you don't have high blood pressure, your cholesterol looks good, and also your functionality. Like you want to make sure people are able to exercise, move about, and feel good within themselves. So when I'm meeting people and doing their initial weight management intake, and we're talking about what their goal weight should be, yes, we can take the BMI into account, excuse me, but it's also like their functional goals. Do they want to be able to hike a mountain? Do they want to be able to run around with their grandchildren? If they have any chronic illness associated with their overweight or obesity, having those in remission or under good control. And then we think about the BMI criteria.
So you spoke a little bit about gut microbiome, and with that, it just reminds me so much of how personalized medicine is starting to get. Tell me a little bit about the impact of gut microbiome on susceptibility to obesity.
Yeah, we actually find that there was a couple of different studies that looked at the gut microbiome of people who were overweight or obese versus maintaining a healthy normal weight, and the flora is completely different. There's certain strains of lactobacillus that are higher in people who have a normal or healthy weight, and others that are lower. So it's like the ratio and the makeup is somewhat different between people who have overweight and obesity and people who are normal, such that they have even considered transplanting like stool or gut flora from normal or healthy patients into patients who suffer from overweight or obesity. But that's kind of extreme, but it's about supporting healthy factors. So things that would support a healthy gut microbiome are your fiber, watching out for inflammatory foods like dairy and excess sugar, and those sorts of things that support a healthy gut flora in general and are also good for your overall health. But we do definitely see stark differences between the microbiome makeup of someone who has a normal BMI and someone who suffers with overweight and obesity.
Yeah, and just for people who are going to be listening audio only, we're saying normal in air quotes. So, let's talk a little bit about genetics. With this conversation about gut microbiome, too, I'm starting to kind of think about the fact that there's a lot of comorbidities as well that are associated with obesity. I want to talk about those comorbidities, but also about how medication and treatment might impact gut microbiome as well. So let's talk about a little bit of the comorbidities that you see impacting obesity or that are associated with obesity and overweight the most. And is there generally a which comes first kind of type of relationship?
So obesity and overweight increase your risk of various comorbidities from head to toe. So we know that people who suffer from overweight or obesity have higher rates of anxiety, depression. It can also increase your risk of developing dementia in older age. We know the cardiovascular disease risk as well. So type 2 diabetes, high cholesterol, high blood pressure, heart failure. Also, I think people are surprised to know that overweight and obesity are, I think, the second highest risk factor for a bunch of different cancers as well. So breast cancer, it's the highest risk factor for recurrence of breast cancer as well. Renal cell carcinoma, which is a type of kidney cancer, stomach cancer. So literally overweight and obesity affect every single organ system from head to toe. I know we mostly harp on the cardiovascular risks, but it really affects a lot of different things, including cancer risk. And that's something that we are talking about more and more because we're seeing a higher incidence of cancer, even in younger age groups. So targeting and managing overweight and obesity has a lot of implications for various parts of health.
Mm. And then with the medications that are often associated with these comorbidities, how does that impact gut microbiome? And what is maybe the causal relationship between some of those um, comorbidities and overweight and obesity?
Yeah, so I would say, so one example that I can think of is, for instance, for people who want to take pills for their diabetes, there's some of them that actually cause weight gain and potentiate the problem. So like sulfonylureas, those are the glipizides, anything with izide at the end, like its last name, those cause weight gain, and that's going to also cause issues with good diabetic control. Insulin also is our bread and butter injectable that we use for management of blood sugars, and that definitely causes weight gain. Every time our bodies make insulin in response to an increase in your blood sugar, or you inject insulin yourself, you also store body fat at the same time. So oftentimes we see people probably getting better blood sugar control on insulin, but they're gaining weight, and they're gonna need escalating doses of insulin to get things down because their weight gain is potentiating the problem. And then we know that a lot of the medications do disrupt your gut microbiome. So a lot of people with overweight or obesity, especially the central, like visceral adiposity, we call it, that central weight gain puts pressure on the sphincter that keeps your esophagus like away from your stomach. And that causes, when it gets weaker because of extra weight gain in the center, like in your abdominal area, that predisposes people to heartburn and acid reflux. And the medication for that we often use are proton pump inhibitors like Nexium or H2 blockers, and that definitely wipes out your gut flora because everything in our body is supposed to work at a certain pH, like in a certain acidic level, and the kind of acronym for this medication, a PPI, a proton pump inhibitor, or H2 blocker, they really suppress your acid production. So that wipes out good bacteria. It lets the bad bacteria flourish. So that upsets the gut microbiome even more. And then people often become dependent on these medications. They develop nutritional deficiencies that cause further issues with comorbidities. So yeah, we see a lot of issues in the management of comorbidities coming from overweight and obesity, and kind of stands to reason that just treating the underlying issue, the overweight or obesity, would give us much better results kind of far down the stream than just targeting each and every comorbidity.
Mm. You mentioned acid reflux, which is something I know a lot of people suffer from. And I know that there are prescription medications for acid reflux, such as omeprazole and things like that. Um, but also people take things over the counter. And so let's just talk about the type of impact that over the counter medications can have on some of the factors that you just mentioned, such as suppressing or changing the pH balance of the gut and things like that. Are those strong enough to do that when taken on a regular basis?
Yeah, because the ones that are available over the counter are just lower dosages of the same things that we prescribe. So often, if people are not getting good control with the over the counter, so for instance, omeprazole that we prescribe is often 40 milligrams. Over the counter, it's 20. But very regularly, people will take two of them. So make the 40 milligram on their own. So thinking it's a lot safer, a lot healthier because you've gotten it over the counter, but still causing the same sort of effects downstream.
And you mentioned things like nutrient deficiencies. That's something that's really interesting to me because, correct me if I'm wrong, if you take, let's take a B12 deficiency, for
Mm-hmm.
example, I know that something like an omeprazole, for instance, might impact your ability to utilize B12.
Mm-hmm.
Um, but then when patients go to the hospital, their B12 levels might be normal, but that's not necessarily saying how B12 is being utilized in their system.
Yep.
And then B12 deficiency or lack of utilization has a lot of other cascading effects, such as,
Mm-hmm.
eye issues, mood things. And so patients with obesity and all of these other cascading kind of results might be seeing different specialists.
Mm-hmm.
So how do you, as a general practitioner, kind of bring all of these things together? Because then we see this information siloed. Someone
Yeah.
goes gets their labs run, and they're like, "Oh, your B12 is fine," but is it really? Like, how do we get around those things to kind of pin down the problem, as opposed to saying, "Oh, you're fine over here. These numbers are good," but we're kind of circling the drain on the real issue.
Yeah, so I think one of the jobs of a primary care or a general practitioner is to distill all of that information and put it into one overarching thing that's easy for the patient to understand and also for us as providers to understand as well. So there's two kind of nuanced things about that. So there's always like what a lab like range says is normal, but what we know is clinically optimal. And then also like you got to go by objective data and subjective data, like what the patient is telling you. So for instance, if I have a patient who comes in and their B12 is in the 300s, on our labs, it might say that's correct. And every lab, depending on where you go, will have different normal ranges because it's based off the population of people that go there and the standard deviation. And that also takes into account people who have undiagnosed deficiencies. So you have to take all of that into consideration. But I know that clinically, people with a B12 greater than 500 do better than if it's still clinically normal but less than that. So I aim to get people's B12s greater than 500. But then you also have to think about what is the patient saying. Are they having anxiety? Are they having pins and needles? Are they having mood swings? Are they fatigued? If they're having those things and their B12 is less than 500, we should treat. So it's about taking what the patient is saying is concerning them and bothering them, and if it's fitting what you know about a deficiency, and also knowing the difference between what a lab normal is and what like an optimal number is for everything that we check in our blood work.
As far as patients advocating for themselves go, or even, for other physicians, whether they're ER physicians or what have you, are there other tests to determine if the nutrient is being utilized by the body versus simply present in the bloodstream?
That's interesting. So I would say in conventional medicine, we have some other markers that we look at. So for instance, for B12 and folate, we look at levels of homocysteine and methylmalonic acid, long, big names, but they are downstream metabolites in some of the major pathways that these vitamins are used in. So you can see if there is actually any downstream effect of a potential deficiency by checking those levels. I would say we call it complementary medicine or like functional medicine. They will do stool tests and saliva tests to actually see more in depth. I personally believe in those things. It's hard to get those things ordered for patients. They often have to pay out of pocket. But yes, I would say in conventional, like allopathic medicine, there are some downstream metabolites that we can check to see if there's truly a deficiency. But I think a broader take is done by our more functional, natural medicine counterparts who test these things in the stool and in saliva as well.
Mm. So let's talk a little bit about inflammation, because a lot of disease, whether you're talking about HS, what have you, a lot of these are inflammation always comes into play. How does overweight or obesity impact the body's tendency towards inflammation?
Yeah, so overweight and obesity, we usually see an enhanced or enlarged amount of fat in that, so adiposity. And people don't realize it, but fat is an organ. Like it makes hormones, it makes inflammatory hormones. We call them cytokines. So oftentimes, actually, if you check, even in our conventional way, our allopathic way, if you check certain markers of inflammation, like a C-reactive protein or a sedimentation rate, those will be elevated in people who are overweight or obese. And you can also check like these levels of some of these cytokines like IL-6, IL-1, and you'll see those are elevated because we often think that fat mass is more cosmetic. We know that it confers some risk depending on where it is, but fat actually makes hormones. So it potentiates a lot of inflammatory based processes within the body.
So, what are the current treatment options for obesity, and how do you determine what's right for different patients?
Yeah, so there are a couple of injectables and then pills that are FDA approved for management of obesity. The pills came first. So there's some that are FDA approved for short term, and those are like your stimulants. So phentermine and its relatives. And you can only use them for 12 weeks at a time. So it's not sustainable for long term management of obesity. But then we have pills that are combinations of older medications that we've used and saw that synergistically they help with managing weight. So one of them is called Qsymia. It's a mixture of phentermine, which we can use short term for about 12 weeks, and topiramate, which we've used for epilepsy, so for seizures, for migraines. Together, we see that they have a good effect on weight loss, about 5 to 7% of a person's starting total body weight. And that medication and the other one I'm going to mention can be pretty expensive, but because they're older medications, you can prescribe the components. Like you can do phentermine separately, you can prescribe Topamax separately, and have the patient pay pretty small amounts, like $5, $10, to kind of create a pseudo version of that medication. But again, it's about 5 to 7% of your starting total body weight. And as I mentioned, more and more people are falling into the higher classes of obesity, like class 2 and class 3. 5 to 7% is not going to be that great of a weight loss. The other medication is another combination medication called Contrave. It is naltrexone and bupropion. And conventionally, we've used naltrexone for a lot of things. So for helping people with opioid use disorder, alcohol use disorder, small amounts termed low dose naltrexone are used for inflammatory, like anti-inflammatory benefits. We see it for certain kinds of headaches, for blood sugar management. So that plus bupropion, which we use for depression and also as an adjunct to help ADD and ADHD medications work better. Together synergistically, we see that it also causes about 5 to 7% loss of your starting total body weight. And going back to the Qsimia, we're not too sure on how it works. We know the stimulant part gives you energy so you can exercise more. It diminishes your appetite. We're not too sure on how the Topamax or topiramate part works. But with naltrexone and bupropion, the commonality is that they both cut down something reward link in your brain. So like naltrexone, it cuts down the alcohol and opioid reward link in the brain. Bupropion, we use that also for smoking cessation. So it cuts down like smoking reward link in the brain. So we think together they also just extend to food reward link, cutting that link down as well. So it's pretty good for people who struggle with stress eating, comfort eating, boredom eating. So anything where they're seeking a dopamine hit for whatever might be going on in their lives, in their environment. So it works pretty well for those people. But again, it's not that much of weight loss. And then now we have the injectables. So we have our GLP-1 receptor agonists, which we are much, much more popular than these pills. Those are actually considered second line now. So our guidelines for managing obesity say, try and get injectables. And then if you can't, whether for accessibility, cost, lack of insurance coverage, then consider these pills. So the first injectables were the GLP-1 receptor agonists, just solely, because now we have dual mechanism ones. So that's basically our liraglutide, which we don't really use because that's a daily injection and not a lot of people want to inject themselves daily. And we have now semaglutide, which is branded under the name Ozempic for diabetes and Wegovy for weight loss, though they're the exact same, so you can use them interchangeably. So a lot of people end up getting prescribed Ozempic off-label, but it's literally the same medication. And then we have what I consider semaglutide 2.0, which is tirzepatide. So that's branded under the name Mounjaro for diabetes and Zepbound for weight loss. Those are incredible at weight management. So the semaglutide based ones, so Ozempic and Wegovy, most people can lose about 15 to 20% of their starting weight. And then with the tirzepatide, so that's Mounjaro and Zepbound, people can lose 30, 40. In my own clinic, I've had people lose 50%, like half of themselves, a whole person on these medications. And those are often more tolerable. So the pills have a lot of side effects, like it can make your heart rate fast. A lot of people who have high blood pressure coincidentally can't take those medications, even though high blood pressure is a pretty common comorbidity of overweight and obesity. So with the semaglutide and tirzepatide, you don't run those risks. A lot of the side effects are confined to the GI system. So people can get nausea or reflux, changes in their bowels, but those are a lot less significant or serious than the possible side effects we saw of the pills. So with the advent of these injectables, we saw more efficacy, more adherence, because these injectables that we use more nowadays are weekly administration rather than having to do something daily. So you kind of can set it and forget it, and more tolerable, less serious side effects. So in every way, the improvements of these medications have been vast.
Mm. It's interesting that you mentioned that some of the medications also help with kind of ADD, ADHD type symptoms, which makes sense because we're talking about that stimulus seeking behavior, especially with stress eating and things like that, which, made me kind of think about this topic of perimenopause and menopause and how it can change how people's brains work, but also how their bodies work. So, how do you see the topic of perimenopause and menopause impacting the efficacy of some of these treatment regimens?
Yeah, so in my practice, I have seen better outcomes for women who are in perimenopause or menopause on the injectables than the pill medications. I think because we know now more and more about these injectables that this is an overarching kind of overused term, but it's actually relevant here. They help balance hormones. So there's also data that suggests, even outside of weight loss, that semaglutide, tirzepatide, they help in various reproductive issues. So they help PCOS, they help endometriosis, they help with infertility because they help with rebalancing hormones and reducing inflammation in the reproductive tract. So not only is it helping weight loss, but it's also helping to rebalance some of the hormones that are more erratic in the perimenopausal state. So we're seeing kind of separate benefits from the injectables, which we don't see with the pills on perimenopause and hormonal imbalance. Also helps the thyroid. It really helps in general because a lot of our processes where there's an imbalance are inflammation driven. Going back to how we talked about actual fat mass producing inflammation. So not only does it help with reducing the inflammatory effects throughout various organ systems, you see the weight loss, but you also see improvement in kidney function, in heart function, in thyroid function, in perimenopausal symptoms, and all those things that are due to inflammation and the imbalance of hormones thereof.
How do you see the impact of medications for things like ADHD, for instance? I'm going to say like a Vyvanse, Adderall, because getting on and off of those things do impact weight as well, and hormones and things like that have a huge impact on how those medications affect people, and whether people feel like they need to take more or less of that. How do you kind of take into account other medications such as those that patients might be on, or changing the frequency of when it comes to helping them manage their weight?
Yeah, so actually, so Vyvanse, it's interesting. So a lot of the psychotropic medications, so medications that work on your brain and your mood, some of them cause weight gain. So things that are like first generation antipsychotics. So things like Abilify, Risperidol, they potentiate like worsen metabolic syndrome immensely. And then you have things like Vyvanse and Adderall, which some people tend to like because it gives that stimulant effect like the phentermine and helps with suppressing your appetite. And Vyvanse is also FDA approved for binge eating disorder. So but what I have found in my patients for both, they end up needing less of this medication. So again, I think when they're on the like semaglutide, tirzepatide, it helps your cognitive functioning in general. So I've had a lot of patients where they're able to lower their dose of Vyvanse. They use their Adderall much less frequently because of they just get improved concentration, focus, cognitive abilities on these injectables as well.
Is there a standard of assessment when it comes to understanding these different factors in patients' lives before the decision is made of how to treat them? Because it feels like some of these factors might come out later on. Maybe when there are side effects or things like that. What is your current approach to maybe gathering all this information on patients to make the best decision for them?
So I'll say there's no standard approach. Everyone does obesity management much differently. But for me, I take all these things into account. When I'm seeing someone for weight management, I have a very long appointment with them, like at least an hour to hit all of these things. So I ask them their weight loss goal always has to include a functional goal, what they've tried in the past, their current medications to see if they are obesogenic, if they have family history of things that, or a personal history of things related to obesity, their mental health, comorbidities, surgical history, like literally everything plays a role in how we should be making a decision on which of these medications is best for someone. I'll say there's no standard, like no standard protocol or algorithm for how people do that. It just takes finding a provider who actually cares about those things to make the best decision for you.
And I think we touched on genetics a little bit, but is there a genetic role in people being more obesogenic than others?
I think so. There are definite genetic mutations that increase someone's risk of obesity. Monogenetic, meaning like one in one gene, but those are very, very rare. Like they are congenital. They come with certain physical appearances that you know from the get-go that that's what that person was born with. There are now more research going into polygenetic, like finding out like what pattern of genes predispose people to weight gain. That's being tested like every single day. But there's also the nuance of, say you're in a family where overweight and obesity run rampant. Is it genetic or environmental? Because you're probably growing up in the same environment, right? So you're probably eating the same foods, having the same physical activity, sleeping in the same pattern. So when we see things that are congregated in a family, it's hard to decipher, is it genetics or is it the environment? Because those two things are shared in families. So it's still important to get that kind of background because it helps you to counsel lifestyle-wise about those things, but it's hard to tease out that difference because those are overlapping things within households.
So how do you broach the topic of weight loss with patients, and what have been some of the common challenges you've come across?
So for me, because I'm an obesity medicine specialist, people get sent to me. So they've already made the decision that they want to lose weight or they want to better manage their weight. So that's a little bit easier for me. But on the other hand, I also am a primary care physician. So my thing is that whenever someone has any comorbidity that we can see related to overweight or obesity, and I'm counseling on lifestyle things because I don't like to do medicines at first, I might bring up like, hey, so there's a couple risk factors for why your blood pressure is high, let's say. I can mention you're sedentary, you're not exercising a lot, you're overeating salt, you're drinking alcohol, and also your weight suggests that it's not a healthy weight for you. Like I always like to root it into a health I don't want to say issue or like an illness that has a relation to overweight or obesity. But I personally will never just, if there's a person in my room and they happen to be overweight or obese, bring it up if there's no like readily discerned health factors. Because for me, my family and including myself have dealt with overweight and obesity, and I haven't had any health issues, thank God, related to it. But it used to be so frustrating to go to the doctor and they'd be like, oh, you're on the scale, you're at the, when you're a child, you're in the 99th percentile for weight, you need to lose weight. And I'm like, okay, great. How? There was never any reasoning how or why, especially if there was no data to support that it was making me unhealthy. So for me, I have it kind of easy in that the vast majority of my patients come to me because they were sent for weight management. But if I'm dealing with my own patients, I like to root it in a health issue or wait for them to bring it up themselves. Because a lot of people now feel empowered to talk about wanting to lose weight because we have actual interventions that work and are healthy or healthier and safer than like what we had in like the 80s with fen that had people dying from cardiac arrest. Like we have true things that work and have other health benefits. So a lot of patients feel more comfortable and more empowered to want to bring up weight loss by themselves.
Mm. So one thing we haven't touched on is bariatric surgery. How common is that these days, and what is the criteria to determine if a patient is a good candidate for bariatric surgery?
So the criteria is shifting a little bit. So it can be a BMI of 35. It also depends on the person's ethnicity too. So a BMI of 35 or of 40 with, or excuse me, of 40 or 35 with comorbidities. So that I see a lot of people less and less actually going the bariatric surgery route because you can get a significant amount of weight loss with these medications. And I've also had a fair amount of people who have undergone bariatric surgery and regained the weight and now are on these medications. Like I have a ton of patients that fall into that category. So I think because no surgical procedures without risks, that a lot of people are trying to at least try to lose weight on their own with these injectables because you can lose a significant amount. And then if that fails, then go the bariatric surgery route because we do, again, have things that can actually work and work well.
So tell me a little bit about what you hope to see in the future and what you're excited about when it comes to treating and preventing obesity in patients.
A lot of things. So again, because obesity affects so many parts of your health, I'm hoping that with the advent of these medications that actually work well, we see a decrease in all of these things. So like a decrease in dementia, a decrease in cancer, a decrease in the incidence and prevalence of diabetes, high blood pressure, high cholesterol, also of other surgeries, not just bariatric surgery, but a lot of people undergo orthopedic surgeries because of undue pressure and degeneration of their hips, their knees. So less of that, which is also less taxing on our healthcare system because surgeries are expensive. And also just less stigma about overweight and obesity. Again, less of thinking that it's something wrong that the person is doing and acknowledging that it is a chronic illness. And hopefully that then trickling down into more and more pharmaceuticals being made to target this, and effectively so. Also hoping for better insurance coverage of these things because we have so much data that they work well. They have other FDA approvals for like sleep apnea, for chronic kidney disease, for heart failure, for stroke, yet it's actually becoming harder for getting insurance coverage. It's like they're blind to the benefits of these medications. So I'm hoping for more insurance coverage, which will increase access and cost of these medications to get it to the populations that need it the most, so that we can see decreases in cancer, in surgical procedures, in dementia, in all of these things that I mentioned before.
Thank you so much for joining us, Dr. Duah. It's been a pleasure.